Let's proceed ahead with the Harrison charts. So coming to the functional classification of hypocalcemia, excluding neonatal conditions. So one is PTH is absent, PTH is ineffective, and PTH is overwhelmed. So PTH is absent in hereditary hypoparathyroidism, acquired hypoparathyroidism, and hypomagnesemia. PTH is ineffective in case of chronic kidney disease when vitamin D is lacking, like that, or vitamin D deficiency, that is due to less dietary intake or sunlight, defective metabolism, anticonvulsant therapy, vitamin D dependent rickets type 1. When vitamin D is ineffective, active vitamin D is ineffective, that is intestinal malabsorption, vitamin D dependent rickets type 2, pseudohypoparathyroidism, and mutant less active PTH. When PTH is high, where there is severe acute hyperphosphatemia like tumor lysis syndrome, acute kidney injury or rhabdomyolysis, osteitis fibrosis after parathyroidectomy. Now coming to the evaluation of patients with hypercalcemia. When there is hypercalcemia, there is key historical considerations. Confirm if CA calcium increases chronic, clues from history and physical findings. If it is of acute or unknown duration, now after that we'll have to check the PTH. If PTH is high or PTH is low. If PTH is high, consider primary hyperparathyroidism, consider MEN syndromes. If PTH is low, consider malignancy, PTH RPSC, and clinical evaluation. If the screen is negative, further go to the further evaluation. Now, if the duration is chronic, again we'll measure PTH is low or PTH is high. If the PTH is high, there are few causes, that is hyperparathyroidism, consider MEN syndromes again. If the PTH is low, other causes like granulomatous disease, it is familial hypocalciuric hypercalcemia, milk alkali syndromes, medications like lithium and thiazides, immobilization, vitamin D and vitamin A intoxication, adrenal insufficiency, and hyperthyroidism. Now, what are the guidelines for surgery in asymptomatic primary hyperthyroidism? If serum calcium is above normal, that is, if it is 1 mg per deciliter more than normal, renal. When the creatinine clearance is less than 60 ml per minute, 24-hour urine calcium more than 400 mg per day, and increased stone risk by biochemical stone risk analysis, presence of nephrolithiasis or nephrocalcinosis by X-ray, ultrasound, or CT. And skeletal by bone density by DEXA scan. If T score is less than 2.5 minus 2.5 and the lumbar spine, total hip, femoral neck and distal 1/3 of radius. Vertebral fracture by X-ray, CT, MRI or VFA. Age is less than 50. So these are all the indications for surgery in case of hyperparathyroidism, even if the patient is asymptomatic. If you think it very logically, the patient should have hypercalcemia. What are the systems does parathyroid usually affect? That is renal and skeletal. So renal, it should have evidence of stones majorly, and skeletal, the bone density should be low, which shows that calcium is taken out from the bones and there is reduced bone density to cause hypercalcemia. Now coming to the classification causes of hypercalcemia, one is very simple, associated with renal failure, that is secondary hyperparathyroidism, albumin intoxication and milk alkali syndrome. Associated with high bone turnover, that is hyperthyroidism, immobilization, thiazides, vitamin A intoxication and fat necrosis. Vitamin D related, vitamin D intoxication, increase in 125 OH, T, that is sarcoidosis and other granulomatous diseases. One is impaired 125 OHD metabolism due to 24-hydroxylase deficiency and inactivating mutations in sodium-dependent phosphatase co-transporters. Malignancy related, especially solid tumors of breast, solid tumors with humoral mediation or of hypercalcemia, that is lung and kidney, and hematologic malignancies like multiple myeloma, lymphoma, and leukemia. Now, very common, that is parathyroid related, that can be primary hyperparathyroidism, it can be adenoma, that is MEN syndrome, or it can be carcinoma. lithium therapy, and familial FHH, that is familial hypocalciuric hypercalcemia. Causes of impaired vitamin D action, vitamin D deficiency, that is impaired cutaneous production, dietary absence called malabsorption, accelerated loss of vitamin D, that is increased metabolism like barbiturates, phenytoin or rifampicin, impaired intrahepatic circulation and nephrotic syndrome, impaired 25 hydroxylation, that is liver disease, isoniazide, and 25 hydroxylase mutation. Impaired 1-alpha hydroxylation is hypoparathyroidism, ketoconazole, and 1-alpha hydroxylase mutation. FGF, that is fibroblast growth factor 23XS, that is oncogenic osteomalacia. X-linked hypophosphatemic rickets, renal failure. Target organ resistance like vitamin D receptor mutation and phenytoin. Others is obesity. So all these are causes of impaired vitamin D action. So these are the scattered hemorrhages seen in diabetic retinopathy. You should know the classification of diabetic retinopathy and it can be asked many number of times. Causes of hypermagnesemia, excessive magnesium intakes like cataracts, urologic irritants, parenteral magnesium administration. Rapid mobilizations from soft tissues like trauma, shock and sepsis, cardiac arrest and burns. Impaired magnesium excretion like renal failure, familial hypocalciuric hypercalcemia. Others is adrenal insufficiency, hypothyroidism and hypothermia. There is nutritional recommendations for adults with diabetes or pre-diabetes. Dietary guidelines: vegetable, fruits, whole grains, legumes, low-fat dairy products and food, higher in fiber and lower in glycemic content. Fat in diet, optimal percentage of diet is not known, should be individualized. Mediterranean style diet rich in monosaturated fatty acids, minimal trans fat consumption. Carbohydrate. Monitor carbohydrate intake in regard of calories. Sucrose containing foods may be consumed with adjustments in the insulin dose, but minimize intake. Estimate grams of carbohydrates in diet type 1. Consider using glycemic index to predict predict how consumption of a particular food may affect blood glucose. Fructose preferred over sucrose. Protein in diet, it should be individualized. Other components, reduced calorie and non-nutritive sweeteners may be useful. Routine supplements of vitamin, antioxidants or trace elements not supported by evidence. Sodium intake as advised for general population.